So this is lab number 8 over the heart and the blood. And let's just take a look and think about the heart for a moment. You did a little bit of pre-lab work. So you know that the heart is a hollow organ. I think we all know that. And you shouldn't be surprised that some folks got together in a room and decided to name those layers of the heart. So the outer layer of the heart, the epicardium. Epi means on. But you know what? Epidermis, right? On the outer layer. But you already know the epidermis from you already know the epicardium, sorry, from a different name. You already know the epicardium as the visceral pericardium, right? The layer that was shrink wrapped on the outside of the heart. So it's the same thing. Epicardium is the visceral pericardium. Same thing. Then the majority of the heart is going to be a very muscular layer referred to as the myocardium. It's in that muscle layer where you find the cardiac muscle that you know and love, that you can recognize under the microscope. You're looking for those intercalated discs. And then finally, if someone has a heart attack, right, they've had an MI, a myocardial infarction. So a lack of oxygen going to the heart muscle. Then the inside layer of the heart is the endocardium. Endo, within. So where the blood is touching inside the chambers, lining the chambers, is just an epithelial layer. The same layer also basically goes over the valves of the heart. And we'll talk about the valves a little bit today. You can have a very serious infection of the heart called an endocarditis. Inflammation of the endocardium. That endocardial infection can not only damage the heart, but more importantly, damage the valves. And if you damage the valves, we've got some trouble. So endocarditis, very, very serious infection. It can be viral or bacterial. The heart. I think we know some of this, but we'll put it all on the screen. 4 chambers, 2 superior chambers, 2 more inferior chambers. The more superior chambers are called the atria, plural. Each one's an atrium, left and right. Atrium means entryway. Your church or home, you may say the entryway is the atrium. So that's just where the blood is entering into the heart. There's going to be on the outside of the heart a flappy structure. It's named as the same as the flappy portion of your ear, the auricle. So when we look at the heart on the models, you've all got a heart in front of you, and I'll show you this in a picture in a moment. But the auricle is a flappy portion on the outside of the heart, and the auricles sit on top of the atria. So you can you have a landmark as to where the atria are on the heart. The atria are receiving blood, like I said, and there's 2 atria, the left and the right. The right atrium is receiving blood from your entire body. It's what we call the systemic circuit. It's the blood coming back to the heart. This blood is not oxygen rich. It has already made its journey through the body. It's coming back needing to be regenerated with oxygen. We'll talk about that. Then the left side of the heart is receiving blood, the left atrium, receiving blood that just came back from the lungs. Now this blood has just been, quote, recharged, re-energized with oxygen, and as we'll see, the left side of the heart is going to pump that blood out to the body to send out oxygen and nutrients. So the blood that comes in on the right atrium goes down to the right ventricle. The blood that comes in on the left atrium goes down to the left ventricle. So the blood goes down to the ventricle on the same side of the heart. The ventricles are the more inferior chambers, and there are 2 very large arteries that come off from the ventricles. One is the pulmonary trunk, and the other is the aorta. And we'll be looking at all this and the color and the orientation of all this in a moment. So I'm giving you lots of words here that'll make a lot more sense in a few minutes. The pulmonary trunk is going to be sending blood to the pulmonary, to the lungs. That's coming from the right side. And the left side is going to be sending blood out the aorta. Okay. Arteries, by definition, always go away from the heart. So they always leave the heart. So these 2 large arteries, the pulmonary trunk and the aorta, are carrying blood away from the heart. So here's a schematic, a cartoon of the heart. Please turn the heart in front of you. If you need to grab another one, we've got extras in the room. But turn the heart so it sort of has the same orientation for you. And Logan, if you need to grab one from over here, do that. So you all have a sort of a heart in front of you that's basically in this same orientation. and then I'll be marking up a few key structures on here. First thing I always note about the heart is that it's very asymmetric, right? This is not something that's perfectly round or perfectly oval and has 4 equal compartments in it. So it's rather asymmetric. Let's take a look at the overall shape of the heart. We'll notice that there's a conical end, sort of a pointy end, and this pointy end is going to be called the apex of the heart. The top of the heart, right, what we think of as being more superior in your chest, up here, this area of the heart is called the base. Now that seems all backwards, right? But in fact, that's the nomenclature. If this were the lungs, right, here's the diaphragm, and the lungs would go up like this. And this would be the base of the lungs, and the point would be the apex of the lungs. But the heart is kind of sitting upside down, if you will, in your body. So the base is on the more superior side, and the apex is down here at the point. We've got these 2 flappy structures. Here's a flappy structure here. This is the auricle. So this is the right auricle, and the left auricle you can see evidence of over there. Those 2 structures, these flappy-like structures, are sitting external to where the 2 atria are. So the right auricle is sitting where the right atrium would be internally. The left auricle is sitting on top of where the left atrium would be. The majority of the heart, the bigger chambers, are going to be the ventricles, and they are internal to this large portion here. On the outside of the heart, you're going to see some arteries and veins, red and blue, and these are the arteries that are going to get blocked if someone's having a heart attack. So these are the vessels bringing oxygen to the myocardium, to the heart muscle. And again, if one of these is to get blocked completely, then someone's going to have a heart attack, and that part of the heart will be damaged. Now, cardiac muscle is unique, not completely unique, but is sort of unique in that it doesn't regenerate. So once cardiac muscle is damaged, it does not have the capacity to regenerate, which is the same as neurons in the nervous system. So you mess up neurons, you mess up spinal cord or brain, you mess up cardiac muscle, they don't regenerate, which is why damage to the heart and the brain are so devastating. Other parts of your body will regenerate largely and grow back, or at least heal themselves to some meaningful level. Once the heart muscle is destroyed, it is replaced by fibrous connective tissue that does not have any contractile strength. So the heart will always be weaker than what it was before the attack. We see some major vessels coming off the heart. Again, coming off the base at the top. Okay, you've got this major artery. This one comes up, flips over the top, and comes back down through here. That is the aorta. Goes up across the top, comes back behind the heart. That's the aorta. And then the other major artery leaving the heart is right here. This is the pulmonary trunk. The pulmonary trunk comes off and then branches and goes left and right. That's the branch that's bringing blood to the lungs to get regenerated with oxygen. 2 large veins are bringing blood back into the heart from the head and from the arms. This is the superior vena cava, bringing blood into the heart from the upper places above the heart. Bringing blood back to the heart from below the heart is the inferior vena cava. It's bringing blood back from the trunk and from the legs. And I think that's about it right now as far as introducing things on the external portion of the heart. We'll have some time to look at that in lab today as we look through the models. What I want to focus with you today is now the internal anatomy of the heart. What do these chambers look like? What controls the movement of blood through the heart? And look at the flow of blood through the heart. So that's our focus right now, the next 20 slides or so, is how does blood come into the heart? Where does it go? What's its pathway? And what's happening to that blood as it goes through the heart? There are 4 chambers to the heart, right? The right atrium, the right ventricle, the left atrium, and the left ventricle. What I'm going to do right now is pause, and I'm going to start drawing on my pad what I would have been putting on the board. I'm going to have you take your image of the heart, that cartoon of the heart, and I want you to turn it over, and on the back side you've got a big blank white space. This is where you're going to use your pencils and your colored pencils, whatever you have, to represent the heart. And I'm going to turn off the slides, and everything that I'm going to say is in your slides. It is in your slides sequentially. Everything is spelled out. I'll be using some abbreviations as I go through this, but when you go back and read through this, it'll all make crystal clear sense. So I'm going to go to a whiteboard, and I am going to use a black marker to draw imagine this is your paper, guys, that you got in front of you, right? I want you to draw a square about this big on that paper. So you're drawing a square about that size on your paper, and now this is that square, okay? And you're going to be overwhelmed by my artistic skills here. They're pretty poor, okay? And we'll see how I do on the pad. I'm going to put in 4 chambers, 1, 2, 3, and 4, and these 4 circles or ovals represent valves. Okay, so I'm going to have 4 chambers of the heart and 4 valves, and I'm drawing this as, quote, a square heart. The heart is asymmetric. The heart is really kind of complex and way outside my skill set to draw, and I have found that most students would have difficulty drawing an anatomically correct heart. So we're going to simplify this as a square heart, and as I go through this, I think it's a good way of learning it, and then you'll apply what you learned here on the square heart to the anatomically correct structure. So here's what we've got going on. We've got some blue, and blood is going to come into the right atrium. So let me go back and label the chambers. This would be the right atrium, RA, the left atrium, the right ventricle, and the left ventricle. Okay? I'll be using lots of abbreviations, like I said. And blood is going to come into the right atrium. It's going to get there by one of 3 ways. It's going to get there by the inferior vena cava, the superior vena cava, or a structure that we'll see later called the coronary sinus, CS. Coronary sinus. So this is blue blood coming into the right atrium. Now this is a big cycle, but this is where we'll start for the conversation. That blood's going to come into the right atrium. It's coming in as blue blood. Blue blood means that it's not as rich in oxygen, and we call this venous blood. It's coming in on veins, inferior vena cava, superior vena cava. It comes into the right atrium, goes through the right atrium, and is going to go into this valve, or go through this valve. Now this valve is going to be called the right atrioventricular, RAV for abbreviations now, the right atrioventricular valve. The other name for this is the tricuspid. Okay, the tricuspid valve or the right atrioventricular valve. These valves are going to make sure that blood can only move in one direction. Okay. Now, if you will, you've got your paper out. As I'm going through this, you're going to see all these words are spelled out in your PowerPoints. So if you have your PowerPoints nearby, you could have those. You'll see some of these words spelled out for you slide by slide. So the blood's going to come into the right atrium, go through the right atrioventricular valve, or through the through the tricuspid valve. Now the blood is down in the where? Right ventricle. Now the right ventricle, when the blood goes to the right ventricle, it's going to see something very different. Imagine you're a red blood cell right now. And when you go into the right ventricle, you're going to see what looks like these cords. Now these cord-like structures, they're connective tissue. They're very white. They're very fibrous. If you open up any of your heart models, you're going to see represented in the ventricle these plastic-like, string-like structures. Those string-like structures are called the chordae tendineae, CT. The chordae tendineae. And those chordae tendineae are going to be attached to the wall of the ventricle by muscles, and I'm going to draw them in here. And these muscles on the side are called the papillary muscles. Okay, I'll try to get them a little bit thicker there. Now, what does papillary mean to us? Nipple-shaped, right? And that's exactly what you're going to see. These nipple-shaped muscles on the wall of the ventricle. So these chordae tendineae are there. They're attached to these papillary muscles, and they're going to be attached up to the valve as well. And these chordae tendineae are going to be important in closing the valve at the appropriate time so that blood is being pushed or allowed to move from one chamber to the next. So we still got blue blood. Everything on the right side of the heart is going to be blue. The blood's now going to be, the right ventricle is going to squeeze, and it's going to push the blood through the next valve. And the next valve is this is going to be called the pulmonary semilunar, PSL for my abbreviations. Okay, the PSL, pulmonary semilunar. It's going where? To the pulmonary, to the lungs. And the valve, some people think it looks sort of like a half moon, semilunar. Now, coming off from the heart, the pulmonary semilunar valve opens up into a very large artery called the pulmonary trunk. I have PT there just to abbreviate it. The pulmonary trunk. Now, the pulmonary trunk is going to split into the right and left. So I've got the left pulmonary. This is going away from the heart, so it's an artery. So I'm just going to label that as the RPA and the LPA. Right? The right and left pulmonary arteries. Where is that blood going? Out the pulmonary trunk, split to the right and left pulmonary arteries. That is still blue blood, right? And that blue blood is going where? To the lungs. So, you're going to be overwhelmed by my artistic skills. There's your lung. 1, 2. Okay? Now, what happens in the lung? This is where the oxygen and the gases will be exchanged, and where the blue blood will add on oxygen. And when blood is well oxygenated, blood is red. So what we're going to see here is that now we're going to be picking up our red pencil in a moment. Okay? And in some books, you'll see purple. And they'll put purple in here to represent the mixture of red and blue, right? So I've kind of got this double helix thing, red and blue. But that represents the exchange of gases within the lungs. So now what? The lungs have just reoxygenated that blood. And now that blood is going to come back through some veins, right? Keep in mind that veins are always going toward the heart, but they're red because these veins are carrying oxygenated blood, aren't they? So we're going to, and I'm going to draw this. I know it gets kind of crazy, right? But we're going to draw blood coming back to the heart. This is red blood. It is arterial blood. It is oxygenated. Is coming in from the left pulmonary vein, right? And the right pulmonary veins, it's plural, there's actually more than one, drops back now blood into the left atrium. Everything on the left side of the heart is going to be red. It's going to be pretty much the same story. The blood's going to come into the left atrium. It's red blood. It's going to go through this valve. That valve, its nickname, this is the left atrioventricular valve, LAV. It's also called the bicuspid. Okay, the bicuspid, because it has 2 points on it. Sorry, my writing's horrible. Bicuspid. And this has another name, you need to know all three of them, the mitral valve. So you'll hear it called the left AV valve, the left atrioventricular valve. You'll hear it referred to as the bicuspid valve or as the mitral valve. To remember the order of these, you try it before you buy it. Okay, so the tri was over on the right side, the tricuspid. The bicuspid is over on the left side. So try before you buy. Now, we still got red blood coming down now into the left ventricle. We still have over on this side papillary muscles, and there's still chordae tendineae. Okay, so there's my little curtains. That represents the chordae tendineae and the papillary muscles on the wall. That blood is now going to be pushed through this valve. This valve is going to be called the aortic semilunar valve. Some books will just call it the aortic valve. So the aortic valve or the aortic semilunar valve. And now, what chamber am I in? Or what, not chamber, what vessel? This is going to leave out of the heart in the biggest artery of the body, and that is the aorta. Just a big A there, the aorta. Now, where is the aorta sending this red blood? Everywhere, right? Everywhere. So, just to showcase my artistic skills, let's pretend it's going to your hand. Okay? Just as an example. It's going all over the place, right? And next week we'll talk about arteries and veins. Next week you'll learn about the names of the arteries that travel through your body and about the veins that carry the blood back. So we will see that. But for today, we just know that one of the places the blood can go is your hand. What happens there? The oxygen is going to be delivered. CO2, waste gas, is going to be picked up. Again, in the fine capillaries of your tissues, some books might mix red and blue to represent the exchange of gases. So I'll put red and blue sort of in the hand, right? In the tissues, we're exchanging gases, red and blue or purple. And then, okay, we're almost done. Now what? That blood is now what color? Blue again, and it's going to come back and go where? Yeah, so I know it's hard, but draw this thing back up around, and we're going to drop back in to, in this case, yeah, because it was the arm, okay? Because it was the arm, it's going to come back into the superior vena cava. Okay, if you drew a foot, it'd be the inferior vena cava. If you drew the hand, it'd come back into the superior vena cava. Whatever, right? Okay? It doesn't look like anything, right? But everything from your brain and your neck and your arms comes back. It's everything above your heart comes back into the superior vena cava. Everything from below your heart, your trunk and your legs drains back up through the inferior vena cava. So if that was a hand, it would come back into the superior vena cava. If that was a foot, inferior vena cava. And around we go. This process takes about 1 minute, on average, for your blood to go from your heart, go to some distant place, and come back to your heart. Now, some of those circuits are shorter. If the blood's going to your big toe, that takes a little bit longer than it does if it's just going down to your spleen. Right? So there's some differences, but on the average, think about this happening every minute. If you were a red blood cell on a magic school bus ride, you would take about a minute to go around the cycle. Okay? So, a couple more modifications to this, and what I'm going to do right now is, do the best that I can, I'm going to soften this point. And why am I softening this point? This corner, I'm softening because that corner represents the apex. Very good. So if you took a scalpel or you took your finger or something and you stick it into the apex of the heart, you are sticking that scalpel into the left ventricle. I'm also going to, again, I know it gets difficult, but I'm going to thicken this. Okay, I'm going to thicken the wall around the left ventricle. And the reason I'm doing that is the left ventricle is by far the thickest of the 4 chambers. And what makes it thicker is a thicker layer of the muscle layer. And the muscle layer is called the myocardium. So that thick gray going around represents a thicker layer of myocardium. And you'll see how much thicker the left side is than the right side in a few minutes. Lastly, before you go home and show somebody your square heart, I want to make sure you understand that this is not anatomically correct, and there are a few problems with this square heart, but I think the problems are easier to deal with than trying to draw the correct thing. So what's wrong with my square heart? Number one, most obvious thing, heart's not square. Number two, the four chambers are not the same size. Okay, in fact, I've got this totally backwards because the atria are actually smaller and the ventricles are larger. The atria are much smaller than the ventricles. And then thirdly, and probably most important from an anatomical standpoint, is that the pulmonary trunk and the aorta do not come off, quote, the bottom of the heart, but they emerge off the top, which we call the base. Okay, so that's a big difference. But man, there's a crisscross applesauce thing going on inside the heart, and you already see how challenged I am by pencil and paper. So for me to draw an anatomically correct heart is not something that's in my toolkit, and perhaps it isn't for you. But we can all draw a square, and we can all take red and blue and label chambers. And if you'll learn this, I don't care if you learn the square heart or, and I'm going to come off now, and as you go through these slides, okay, you're going to see that I've gone through everything in here. Everything I've said and abbreviated has now been laid out for you in these slides. And after you have gone through this, and as you go through the list of structures today on the heart, I don't care if you learn the square heart or if instead you learn a flow chart that looks like this. Okay, it doesn't matter. It's the same thing. Some people like flow charts, some people like square hearts. You choose. But let's take a look at this image. What I want to point out to you, since your PowerPoints, and this is in your PowerPoints, turn over there, your PowerPoints aren't in color, so I want you to note right now that everything on the top of this is in blue. Right? Everything on the top of this cycle is blue. Everything on the bottom of this cycle is in red. Say it again. Yeah, and the two, yeah, right. And you got purple showing up here too, right? So I'll go through that in a second. Good, Logan. So let's take a look. So here, we'll start right here, because this is where we started already before. The right atrium, it's receiving blood from either the superior or inferior vena cava. What's not listed here, just for completeness, is that thing called the coronary sinus. So you could add that, and then that'll make more sense to you later. But put a little CS there. I know it's awfully small, but put a CS there as a reminder for completeness. So the blood is now in the right atrium, and where does it go? Through the right atrioventricular valve. Its nickname, though, was the tricuspid. So put a tri below there as a reminder. Through the right ventricle, out the pulmonary semilunar valve. Some books will just call it the pulmonary valve. Into the pulmonary trunk. The pulmonary trunk is an artery. It's a blue artery, but it's an artery going away from the heart. The pulmonary trunk will split into right and left pulmonary arteries. And now we're heading to the lungs. We see purple, right? Gas exchange is happening in the lungs, purple. The blood now leaves out of the lungs. It's now red blood, and it enters into pulmonary veins, left and right. They come back to the heart into the left atrium, travel down through the left atrioventricular valve. Two nicknames, mitral and bicuspid. Okay, so the bicuspid or the mitral valve. Through the left ventricle, out the aortic semilunar valve, or just the aortic valve, into the aorta, off to all body places, arm, legs, you name it, liver, brain. There gas exchange happens, red oxygen's dropped off, blue CO2, blue blood is formed. That blood comes back to the heart through a series of veins, which then all drain back into the superior or inferior vena cava. So I don't care, square heart or this story. The square heart has a few more details in it. And honestly, when you get to the cardiovascular system, and I know you're a little bit ways off in lecture, but a lot of my students will turn their test over the very first day and actually draw out the square heart. Now, by the time you get to the heart in your lecture, you may already know this so well, you don't need to draw out the heart. But next week on the quiz, you may find yourself right, throwing over your quiz and either drawing out this flow chart or the square heart. Now, if you are really artistically gifted, you may instead want to draw this out. It's not my cup of tea. But this is the anatomically correct heart. The 11 steps over on the side are the same 11 steps that we went through. And if you look at this, and I won't go through it right now, but you look at this and you'll see that the right side of the heart is all blue, the left side of the heart is all red, the valves are in place, you see the gas exchange happening in the lungs and in the tissues. So it's all here, right? But most people are not going to jump into this first time. They're going to do the square heart, look at the heart today, and then go back and follow this through the 11 steps. Any questions right now on the heart? That's where I'm going to stop when it comes to the heart. We're going to look at the heart model. We're going to go to page 396 and 397. That's where you'll find your model inventory list of the heart. And even before you go there, I want you to take your pencils representing red and blue and actually turn over your square heart to the anatomically correct cartoon of the heart. And I want you to spend 5 minutes labeling your heart. And on this heart, I want you to label the following things. I want you to definitely be able to label, you should be able to label the chambers. You should definitely be able to label the 4 valves. You should be able to label the aorta, the pulmonary trunk, the pulmonary arteries, and the pulmonary veins. You should also be able to label on this image the papillary muscles, PM, the chordae tendineae, and you should have the correct color, red or blue, going through that part of the heart. So take a few minutes right now. You can use a picture. If you turn in your Amerman book, I had you turn early. If you turn in your Amerman book to page 395, you will find on the bottom of page 395 a beautifully drawn out heart that is in basically the same orientation as the cartoon that you're coloring on. So use the bottom of page 395 as your guide right now as you are coloring this in. So now that you've looked through the heart and you've looked at all those structures, make sure you do specifically look at the areas of concern, the coronary sulcus. Make sure you, and put next to coronary sulcus, atrioventricular sulcus. Make sure you also can clearly identify the anterior interventricular sulcus, the posterior interventricular sulcus. And then also make sure you can identify inside the atria, between the left and right side, the fossa ovalis. And read about in your chapter how in the fetus that was the foramen ovale. Let's now turn our attention to blood. And blood is a connective tissue, right? We remember some of this conversation from histology in week 3, and you've been tested on this as well. When you move past the nervous system in lecture, you'll also have a little unit completely on the cardiovascular system. For my students, exam 5 is completely cardiovascular. So it'll cover the heart, the blood vessels, and the blood. And I believe you'll have a similar experience with Mr. Macauley. We know from everyday experience that blood is thicker, more viscous than water. And if you were to take the temperature of your blood, it's going to be about 1 degree Celsius warmer than your body temperature. Okay? And what that means is that your blood is a nice warm environment. And it's also very nutrient rich. So should bacteria get into your bloodstream, right, and that bacteria will be very happy. It's a warm, nutrient rich place. And diabetics actually are at higher risk for blood infections because they have more sugar in their blood. And so bacteria are even happier in a diabetic's blood should they get into their bloodstream. We can take blood. And you won't be doing that this semester, but next semester in Biology 106, you'll actually be taking blood and spinning it down in a centrifuge, separating it out into its components and examining that. And when we do that, what we're going to see is we're going to get 3 basic layers of blood. We're going to see erythrocytes. Erythrocytes are your red blood cells. Erythro means red. And all of your red blood cells are going to pack down toward the bottom of this tube. And I'll show you this tube in a moment. That's going to account, on average, for about 44% of your blood volume. Now we're going to see that women and men have slightly different percentages of red blood cells, but we're going to say across all individuals, about 44% of your blood volume will be composed of these little things called red blood cells. Then there's going to be a little tiny layer when you spin it down, there's going to be a little tiny layer called the buffy coat. It's the middle layer, and it's in the buffy coat that the white blood cells, the leukocytes, and the platelets, the fragments involved with blood clotting, they're going to pellet out. Then the largest fraction is going to be the top fraction called the plasma, and plasma is the liquidy portion of your blood. If we're talking about connective tissues, plasma would be the ground substance, right? The stuff outside or around all of the blood cells. It's going to be mostly water. It's also going to have some proteins dissolved in it, and gases, hormones, nutrients, waste products, you name it. Everything that's floating around in your blood is being carried through this plasma. So here's what this would look like. You're going to take some blood. Normally we take blood, not all the time, but normally we take blood from this region. What's that region called? The inside of your elbow area is called the antecubital region, right? The AC region. And normally we take blood from the AC, from the antecubital region. What are we aiming for? When we give blood, are we going for an artery or going for a vein? A vein, right? Typically you're looking for that big old vein that sits there in, there's a median cubital vein that goes right across that antecubital region. And we're going to grab blood from that vein. Why do we grab blood from a vein and not an artery? We'll talk more about this next week, but we might as well think about it. Veins are? They don't have fresh blood in them. That's true. They're going to be, quote, blue blood. Now, is the blood truly blue? No, it's red, but it's not as bright red as arterial blood. But there's something else very practical as to why we poke a needle usually into a vein and not into an artery. The direction of the blood flowing and the pressure under which that blood is found. Arteries are under tremendous pressure. If you cut an artery, it squirts. It squirts and it doesn't heal up very well, and you're going to lose quite a bit of blood. As a vein, it's under very little pressure. So when you puncture into a vein, do venous puncture, you're going to get blood out, but it's going to blip, 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 blip. It's not going to be under high pressure, and it'll clot off very easily as a result. Okay, so there's a few different reasons. Thirdly, and probably equally important, is that veins are toward the surface of your body. And arteries, being under greater pressure and more damaging to your body if you sever them, arteries are deeper, more hidden, more protected in your body. So when you look at your wrist, right, you see all the blue, those are all your veins. The veins are toward the surface, the arteries would be deeper and more protected. So we take some venous blood, typically, we take some blood out of the vein, and we put it into a tube. And now we put that tube into a centrifuge, spin it for about 5 minutes, and now take that tube out. And what we'll have is a centrifuge tube, a little test tube, and the bottom, right, will be all red blood cells. That's going to account for about 44% of the blood. There'll be a little tiny layer in the middle called the buffy coat. That's where the white blood cells and the platelets will pellet out. And then the majority of it, everything on top, will be plasma. It'll be a light colored. It won't be water. It'll be clear, but a little bit foggy, kind of a tannish color. Oops. So next semester, we'll dive into this a little bit deeper. You'll hear a little bit more about this in lecture, I'm sure, as well. But if we were to think about what is in the blood, again, the bottom layer is just red blood cells. Now, red blood cells are very uniform in their shape. We saw red blood cells back in lab 2 or 3 when we were talking about hypo and hypertonicity, and saw that red blood cells are very flexible and they change their shape rather easily. But they are 7.5 microns, right? We want to keep in mind their shape. They're very uniform in shape. What I also want to point out here is the numbers. Look at this number, 4.2 to 6.2 million red blood cells per cubic millimeter. So a cubic millimeter, can you picture it? I mean, a little millimeter, make a little box, a little cube out of a millimeter, right? Each side's a millimeter. The volume inside that cubic millimeter is also a microliter. 1/1,000,000th of a liter. So within 1/1,000,000th of a liter, a minuscule little drop of blood, there would be between 4 and 6 million red blood cells. It's an astronomical number of cells, right, in a very small area. Which is why about 4 weeks ago, I didn't have you looking at red blood cells under the microscope. We weren't quite ready to see things that small, right? It's just tough to see sometimes. Then, in the buffy coat area, you're going to have platelets and your different types of white blood cells. We'll name them specifically next semester. For now, just call them white blood cells or leukocytes. And then in the plasma, again, it's 92% water, about 7% proteins, and the rest of it, your nutrients, your sodium, your potassium, your gases, everything else that's dissolved in your blood and being transported around in your body is found in the plasma. So, I've already said all this, I believe, but red blood cells, right, and members of the buffy coat. So the buffy coat, again, was your platelets and leukocytes. Collectively, we'll call all of the cellular-like structures within your blood the formed elements. Now, there's a kind of a technical reason why we do this, and that is that platelets aren't cells. So we don't want to call them just the blood cells. We instead call them the formed elements, and you'll hear more about this as we go through. If I take all the formed elements, the cellular components, and the plasma, that is whole blood. So when you go down and you donate blood, if you've done that, you're donating whole blood. They're taking everything, right? They're going to take about half a liter, about 500 mils of blood from you. You only have about 5 to 5.5 liters of blood altogether. They're taking about 1/10 of your total blood volume. And because they're taking a rather significant amount of blood, they're going to make you wait how long before you go back? About 6 weeks, right? Usually about every 6 weeks they'll allow you to donate blood. They need to give your body some time to recover from that. So who's given whole blood? Anybody given whole blood? So that's whole blood. Anyone ever given plasma? Okay. When you give plasma, it's a little different scenario. When you give plasma, they're going to pay you for it. You can go down to the plasma center and they'll pay you. They're going to take they're going to take whole blood out of you. They're going to let that whole blood go into a machine. That machine is going to take the plasma out and basically send the formed elements back into the other arm. So they're going to be keeping the watery portion and they're giving you your cells back. They're giving you your red cells, your white cells, and your platelets back. So you can give plasma more often because really what you're donating is water plus proteins and enzymes and things that are in very, very small concentration, low concentration, but are needed for patients who have blood disorders.
Most of the machines now, you just do it all in one.
All in one. Good point, right? So the newer ones, it's not 2 lines, but one kind of in and out.
It stops in between at certain intervals.
Right, it stops at different, so just one poke, not 2 pokes. But you can go down to the plasma center often. You can go down every couple days, right? You can go down 3 times a week, and each time they'll give you some money. And in this country, we can't sell body parts, and we can't sell blood, but they can pay you for your time. So they're going to pay you for your time, sort of as a kind of get around it. And like I said, you can go down. You can probably make, I don't want to overspeak it, but they'll give you little bonuses if you go often. They'll bring a friend. They'll give you a bonus.
I usually make about $60 a week.
$60 a week. You can make a car payment. Okay? You can make a car payment by giving blood. I've thought about bringing the whole family down. Just line them up. Let's all give blood. We can probably pay for the mortgage, right? But it is a way, and you are doing a good thing, and they are safe, and it is clean. But you can go down and give plasma 2-3 times a week and make a few bucks off the side as well. So again, I'm going to give you some details here that are not going to be quizzed on next week, but I just want you to start thinking about blood a little bit more completely. Erythrocytes are involved with transporting oxygen. That's all they do. And females are going to have fewer red blood cells than males. So I told you 4 to 6 million red blood cells. Here I'm giving you slightly different numbers, but women are going to have less than 5 million. Men are going to have the higher number of red blood cells per microliter of blood. Red blood cells hang around in your blood for about 120 days. White blood cells have nothing to do with oxygen carrying. Their job is to fight as part of your immune system. And they are far fewer. Only 5 to 10,000 of these white blood cells per microliter. That's still a lot of cells per little drop of blood, but nothing compared to the millions of red blood cells. And then finally, the platelets, they're involved with blood clotting. They're going to hang around for about 8 to 10 days, and their numbers are sort of intermediate in the hundreds, 100, 200, 300,000 per microliter. Now, the only number I want you to know about this week is the hematocrit. This term, hemo or hemato, means blood, and crit, separate. So when we take some blood and we put it into a test tube and we spin it in a centrifuge, we're separating the blood out into the air, into its layers. So we call that hematocrit. Now the value we get in a hematocrit is actually the percentage of red blood cells in your blood. A moment ago I told you on average across all people, 44% of your blood is made up of red blood cells. That means that on average, the average hematocrit is 44%. But men are going to have higher hematocrits on average. Women are going to have lower hematocrits on average. Males, I always think hovering around 50% plus or minus. Women, down hovering around the 40s, okay, low 40s typically. If you have less than the normal range, you are said to be anemic. Okay, so if you have a lower hematocrit, that means you have fewer red blood cells. If you have fewer red blood cells than your body should have, that means you can't get as much oxygen to your tissues. And if you can't get oxygen to your tissues, you're going to be very weak, very anemic. Your color won't be good, right? You won't have the red color from your complexion because your red blood cells also carry your reddish complexion. Now, children's ranges I'm not going to worry about children, they vary a little bit. And altitude is another thing that can affect your hematocrit. If you were to fly out to Denver right now and try to do your normal exercise routine, you would find yourself huffing and puffing very, very quickly. And what's different in Denver? Higher altitude, which means less what?
Oxygen.
Not less oxygen, but less atmospheric pressure. I know it's kind of splitting hairs at this point, but there's still 21% oxygen in Denver. The difference is there isn't as much atmospheric pressure, and it's actually the pressure that pushes the air into your lungs. There's just as much oxygen in the air, but there's less pressure pushing the oxygen in. So effectively, your body doesn't get as much oxygen, right? So it's kind of splitting hairs a little bit, but I don't want to be incorrect. It takes about 3 to 5 days for your body to adjust. And the reason is your body will adjust to that higher altitude by beginning to make more red blood cells. Thank you for stopping in. Listen to this and you can pick up the rest of the information. Okay. So if you go to Denver, 3 to 5 days later, you'll start exercising again and you'll feel fine. It's why most teams go out to play the Broncos. They're going to get out there a couple days early. They got oxygen on the sidelines because the players oftentimes are feeling a little bit overwhelmed by the oxygen differences. And it's also why if you want to train for a run, it'd be better for you to train for a while in higher altitudes, and then right before the race, come down the mountain to sea level and run your race. Because your body will have been training at higher altitudes, will have, as a result, more red blood cells and a higher hematocrit, and basically it will be legal doping. You will now have more oxygen capacity in your blood as you are running that race. Now this is what people are getting in trouble for, right? They're doing artificial doping. They're actually giving themselves medications that cause their hematocrit to go up, and that's illegal in most sports. But if you just spend some time in the mountains and come down, that's just called a vacation. Okay, people are doing it, right? So let me give you. There's a couple more numbers here I want you to appreciate, and these are astronomical numbers. Every red blood cell, right? We just said there's millions of them in every drop of blood. Every red blood cell itself has 280 million molecules of a protein called hemoglobin. Hemoglobin, heme, is a molecule found on this protein that carries oxygen. Every hemoglobin molecule can carry 4 oxygen molecules. That's max. And when hemoglobin has all 4 oxygens attached, it is bright red. Blood is bright red when it's fully oxygenated. That's why we say that arterial blood is red. The blood leaving the lungs, freshly oxygenated, is arterial blood. It's bright red. When when all 4 oxygens are not bound to hemoglobin, or there's none at all, but 3 or less, now that blood is a deeper red color. When you give blood, for those who have given blood into the tube, right into the bag, what color is your blood? When you look down and you look at the blood that you're giving from your vein into either a tube for the doctor for a blood test or for donating blood, that blood is kind of a darkish red, brickish kind of brown. It's not bright red. Now you cut yourself, the oxygen is right there, and you cut yourself, your blood's going to be bright red. But your venous blood is a darker, bricky red, and we perceive it for reasons I honestly don't completely appreciate. We see venous blood as blue. So when you look at this blood through your skin, you see kind of a bluish-green tinge. And for that reason, we call it blue blood. It's not really blue. It's still that dark brick brown, but we perceive it for the physics of the skin and how the light goes through. We perceive it as blue. Now, this gets us finally to the blood typing conversation that we need to have. And this is where students need to be listening really, really carefully. Each of us has red blood cells. Those red blood cells are carrying on their surface a protein that is referred to as a blood antigen. There are 3 different antigens that we're going to be looking at. We're looking at the A antigen, the B antigen, and what's called the RH antigen. You inherited these from your parents. There isn't right or wrong, there just is. You have a combination of antigens on the surface of your red blood cells. So you may have type A blood, which means you have A antigens on your blood. You inherited it from your parents. Or you may have type B blood, in which case you inherited those B antigens on the surface. You may have inherited both. You have type A, B blood, or you may not have inherited either one, in which case you have type O. So type O blood is the absence, think the null, the absence of A or B. So it just is, right? It's just the way it is. And we learned years ago that these antigens are very, very important in determining who can receive blood from a donation. Now, this wasn't the issue, years and years ago, they didn't know what the difference was, but they knew that you couldn't just give blood to anybody else. There were some issues going on with blood transfusions. And the majority of the issues has to do with these antigens. You cannot receive foreign blood into your body. If you receive foreign blood into your body's immune system will go on hyper alert and will begin to attack that foreign blood. That's what you want your immune system to do. You want your immune system to fight off foreign things. If you have a virus come into your body, if you have a bacterium come into your body, you want your body to fight off that foreign stuff. Same thing with receiving foreign blood. So what identifies your blood are these things called antigens. Okay? antigens. I see those last 3 letters in there and I think, okay, I received these through my genetics. Antigen, right? Genetics. I received them, I inherited them from my parents. They come in 2 flavors, A or B. Okay? But your body makes antibodies against the antigen. These 2 A words get us thrown into a tizzy sometimes. When you get immunized, why do you get the flu vaccine? They're going to inject into your body some antigen, some foreign antigen, foreign bodies. Your body, in response to receiving that foreign antigen, is going to make antibodies against that foreign thing. So that the next time your body sees that foreign flu bug, your body already has the immune function to fight it off very efficiently. Same idea here. Same idea. So your body is going to make antibodies against anything that it perceives as being foreign. Okay? Now these antibodies are floating around in your plasma. They're in your blood. If you are transfused, if you receive blood of an incompatible type, your antibodies will fight off that foreign antigen blood, cause it to clump, and as a result, you could suffer significant tissue damage or even death from receiving the wrong blood type. So we need to understand this, okay? So we don't want to receive the wrong blood type. Here is a cartoon of a red blood cell. Let's try to make sense of this. This red blood cell has on its surface, as an example, it has the A antigen, shown as a square. It has the triangular antigen, shown as the B antigen. And it has the RH antigen, shown as a little Lego piece. Right? Little Lincoln log piece. This person has AB positive blood. The reason we're going to say that they have AB positive blood is their blood has the A antigen, it has the B antigen, and whenever you have the RH antigen, we say that you have positive blood. If you don't have the RH antigen, if this was gone, if there was no RH antigen, then this person would have AB negative blood. So the presence or absence of RH is positive or negative. So that's sort of the cartoon representation of one of the blood types. Now, how many different blood types are there? Within this type of what we call ABO blood typing, there are 8 different blood types. Let me just write them down here, and once I say them, you'll know what I'm talking about. There's going to be, as this one shows, AB positive, but there's also AB negative, right? Then there's B positive and B negative. There's A positive and A negative, and there's O positive and O negative. So there are 8 different blood types, right, floating around here when we consider the RH factor plus or minus. Let's go through this chart. I know it's a little bit small. Understanding this chart will make the rest of the day go really, really easy. Firstly, this person has type A blood. What does that mean? It means that on the surface of their red blood cells, they have inherited and have this antigen A. It's showing up here as little blue pins. If you have A blood and you have on your red blood cells A antigen, you would make antibodies against B. Because B would be considered foreign, your immune system would fight off B and would have these B antibodies in your blood. If instead you are type B blood, it means that you inherited from your parents the B antigen, shown here as purple spikes. If you have B blood, you would make antibodies against foreign A. If you inherited both A and B, you have type AB blood. You're going to express both the A and the B antigens on the surface. Because your body is used to seeing both A and B, it's going to make no antibodies at all against this particular A or B. You're not going to fight off your own blood. Finally, if you inherited neither A or B, you are going to be said to be type O. If you're type O, you have naked little red blood cells. There is no A or B on the surface. But both A and B to your body's immune system would be considered foreign. And so you would make antibodies against both A and B antibodies. Okay, you're going to make both A and B antibodies. Now, that's 4 blood types. Now, let's superimpose on top of that either the presence of or the absence of the Rh antigen. Here, that Rh antigen is called D, just to confuse us. The Rh antigen was first described in rhesus monkeys, and for that reason, the Rh vocabulary has stayed with us, but in other books, they'll call it the antigen D. Don't be surprised, it's the same thing. If you have the D antigen or the Rh antigen, you are said to be Rh positive. You would not make antibodies against Rh. If you did not have the Rh antigen, then you are Rh negative. Okay, so now you got 8 types. Imagine plus and minus Rh for each of these other 4. If you have O negative blood, you are considered the universal donor. Your red blood cells are naked. They don't have A, they don't have B, they don't have Rh. This is the kind of blood that the EMS crew is carrying on the ambulance. This is the kind of blood that they're carrying on the battlefield. This is what can be given to anybody in an emergency because it doesn't have any foreign antigens on it. Anyone can receive O negative.
So what if they needed a blood transfusion, what would they use?
O negative. In an emergency. Everyone can receive O negative.
Right.
Hold on. I know what you're saying. And the answer is O negative. But hold on. Okay? Don't ask the question, but that's the answer. Okay. Now, AB positive, if you have AB positive, it's going to look like that picture just before this. You're going to have the A, the B, and the Rh on the surface. You have all of the antigens. Your body has been seeing all of those antigens all of your life and will make no antibodies against any blood type. So, if you have AB positive, you are considered the universal acceptor, recipient. You can receive anyone's blood. All 8 blood types, you can receive. If you have O negative, the blood bank is calling you constantly. They want your blood because yours is the most needed in any emergency. Anyone can receive O negative. If you have AB positive blood, they're probably not going to call you because your blood is rather rare, number 1. Number 2, if you are AB positive and you are in an emergency, what blood can you receive? Any of them. So why bother bagging up AB positive blood? It really doesn't have much use in an emergency situation. So they might not even take your blood because it's not worth the time, the money, and the resources to bag it, type it, store it, all that good stuff. Okay? They might take it, but they may say, thanks, but no thanks. We don't need it right now. Now, what we're going to be doing today, next week, is typing your blood. We're not going to do it today. Next week, you're going to have the option. This is a voluntary optional activity to type your blood. In a few minutes, I'll pass out a form to you. I'll describe it to you. And you can make your decision between now and next week. And you can change your mind. But each of you will be given the opportunity to type your own blood. How many in here know your blood type? About half. How many have no idea? The other half, right? It used to be, when I was born 50 years ago, Mama was handed a birth certificate and a piece of paper that said your baby has type O positive blood. They don't do that anymore. And I think it's because of privacy. If you watch enough Montel shows, right, who's the baby's daddy kind of shows, you know that blood typing can't disprove paternity, but it can certainly, monkey up the picture of who's daddy. Now, Mama may not even know who daddy is, but Daddy may certainly be surprised to find out that he's not daddy. So I think that's part of the reasoning is that we no longer include blood typing. That's my suspicion. It's not expensive. It's not difficult. We already poked the baby's heel for other things. So it's not an issue of pain to the baby or resources. I think it's a privacy issue. Okay. Now, if you want to find out your blood type, you either have to be in an accident and require potentially transfusion or give blood. At the age of 16 or older, you can give blood. I think it's 16. And now you'll get a donor card that says, hey, your blood type is. And you'll know. Okay. Now, here's a picture of why you don't want to get the wrong blood type. This guy is type B, okay? He's type B. Someone didn't read his blood type or didn't do what we call a cross-check, didn't check twice, and they're donating into him type A blood. In this cartoon, the donating type A red blood cells are shown in purple just so you can see them, right? So this is an adult. He has B blood. His red blood cells have B on the surface. But his blood would also have antibodies against A. So he would have what we call anti-A in his blood, ready to fight off the foreign blood. The moment that foreign purple red blood cell comes into his body, the antibodies to A will find it and will form a clump. Now that clump is actually the beginning of the body's way of getting rid of it, right? You want your body to get rid of that foreign thing, but that clumping is also stopping blood flow down this vessel. And if this is your brain or your liver or your kidney or some other critical organ, you could be sustaining significant tissue damage to that organ, right? So, or death, right? If it were a big artery, a lot of arteries got plugged. So you don't want to be mixing and matching the wrong blood. So we're going to learn about what that means today, so none of us are ever guilty of killing somebody, right? We don't want that to happen. Lastly, I'll let you read through this, but there's a scenario that occurs with with newborns and moms. Let me describe it to you. Pictures are easier. The words are right before this. If mama is Rh negative, that means that she is what? She's either O negative, A negative, B negative, or AB negative. She's one of the 4 negative blood types. And she has a baby, and daddy was Rh positive. Baby has inherited the Rh factor. No problem. So the baby has Rh positive blood, right? The baby's O positive, A positive, B positive, whatever. That's fine, but childbirth's kind of a bloody mess, and there's always going to be some of the baby's blood that's going to get into the mother's circulation at some point during the pregnancy and during birth, especially during the placenta disrupting. Everything's fine. Baby's fine. Mama's fine. But mom is now going to start making antibodies. Mama's going to start making antibodies against the baby's positive blood type. She's fine. But now her immune system just got energized. It's almost like she got a vaccine against Rh positive blood. The next pregnancy, in which she also has an Rh positive baby, her antibodies can cross the placenta and actually can attack the baby's red blood cells. And this can be a very serious anemia for the baby and even kill the fetus. And this is called the hemolytic disease of newborn. It doesn't have to be just the second pregnancy, but the next pregnancy that the person has, a negative mom has a positive baby. She could have had 3 or 4 babies in between that were negative and had never effect. The next positive child has the issue. How do we get around this now? In our environment, this is no longer an issue. Around the 7th month of pregnancy, and then again right after birth, mama's going to be given a shot of Rogam. And Rogam is simply, I think of it as a sponge. And it's going to clean out any of the baby's potential antibodies or blood from her bloodstream and prevent her from making this antibody. So it doesn't matter who daddy is, but if mama walks in and she's O negative, A negative, B negative, or AB negative, they're going to give her this shot, again in the 7th month, and again right after birth to prevent this HDN, this hemolytic disease of the newborn, from occurring. Not a problem anymore in our society with good prenatal care. It is still a problem in the developing world, and it's why you hear your grandparents, your great-grandparents, right? You'll hear about, they had 11 kids, or, she was pregnant 18 times, but only had, 8 kids or whatever. A lot of this had to do with this sometimes. There was natural abortions and natural miscarriages occurring in part because of this condition. But now we don't have it happening anymore. Okay, so that is the story that I want you to know going into a conversation. We've got 15 minutes for this conversation. It's going to go really well. Turn, please, in your Amerman book to page 444. I think I'm right about this. Page 444. And there you're going to find a table with blood types. Am I correct? Am I not right? Not page 444. What is it? Not 444. How about, it's going to be in your blood chapter. So I'm just off of my page numbers. Sorry about this. Go back to your blood. And I want to look for... 477.
Ow.
Whatever I said, 477. There's some repeating numbers in there, right? 477. We're close. 477. And we're going to talk about blood typing. And we're going to figure out who can receive and who can not receive blood. And here I have a particular way of doing this that I think is user-friendly. You decide in a few minutes. I'm going to draw, and I want you to find a white space somewhere in your PowerPoints or a piece of paper. I know that at the end of your PowerPoints, you've got some white space, yes? At the end of your PowerPoints, you should have some white space, a couple of boxes with some white space. After that hemolytic disease of the newborn slide. And in that first box, I want you to draw a circle. That circle represents a red blood cell. I'm telling you right now that this blood cell is A positive. So this is a person who has A positive blood. And I'm going to ask 5 questions that you need to answer about this person with A positive blood. The first question is going to be, and I'm going to abbreviate this, but say it out loud. What antigens are present? What antigens are present on the surface of this red blood cell? So if you have A positive blood, what's going to be on the surface of your red blood cells? A antigen and RH antigen. Perfect. I'm going to put a number 1 there because that's my answer to question number 1. Question number 2. What antibodies will be produced?
Just B.
So, I'm imagining now that I have A positive blood. What is my body used to? A and RH. What would be foreign to my body? B. So I'm going to make anti-B. And that's my answer for number 2, right? So I'm going to have A and RH antigens on my surface, and I'm going to, as an individual, make antibodies against the foreign B. Next question, number 3. What blood types can I not receive? What blood types can I not receive if I'm A positive? I'm going to draw this as an inward arrow with an X through it. And I'm going to put number 3. I cannot receive what blood? Well, what antibodies am I making? B. So I cannot receive anything with B in its name, otherwise it'll clump. So I cannot receive what blood types have B in their names? B positive and B negative. And AB positive and AB negative. Okay, so there's 4 blood types that I cannot receive. They all have B in their name. Question number 4. What blood can I receive? What blood types can I safely receive? I'm going to draw an inward arrow, number 4.
A positive and negative and O positive and negative.
All the other ones. Exactly, right? So I don't even have to think about this question. It's whatever I didn't answer for 3, I can now plug in for question number 4. So I'm going to tell I can receive A positive and A negative, O positive and O negative. Now, 2 of those make sense to me already from our conversation. If I have A positive blood, I better be able to receive A positive blood. That makes sense. If I have, and remember, everyone can get O negative. Right, so 2 of those don't surprise me at all. Now, finally, number 5 question, and where am I going to put it? I don't know. Number 5 question, to whom can I donate? To whom, I'm just going to put donate question mark. To whom can I donate blood?
A positive and AB positive.
Who am I giving? I'm going to draw this as an outward arrow. Okay? I'm going to draw this as an outward arrow. I'm giving away what? When I give away my A positive blood, what am I giving to the person receiving it? A and RH. Right? The red blood cells that I'm donating have A and RH on their surface. So that means that the person receiving them better be okay with receiving A and RH. People who can receive A and RH are people who already have A and RH. So who are they?
A positive and AB positive.
You got it. So the people with A positive blood, no surprise, A positive giving to A positive. But also, people with AB positive blood, I know this is messy, but people with AB positive blood can also receive my blood. Well, that makes sense too, because I've already said what? AB positive individuals can receive all blood anyway. Okay? So on the board it says next week's quiz, blood typing 5 questions. Those are your 5 questions. Now let's take a moment, and I like the drawing out of this. I think there's something about physically drawing it out, not trying to memorize it. But I do want you to put this into the table on page 477. You see a table, all 8 blood types are shown. The very first one is A positive. Let me go across the top of this and put numbers on the columns corresponding to my questions. I will ask you the same questions every single time. So column number 1 says antigens present. That's my first question, isn't it? What antigens are present? So put a 1 above that column that says antigens present. The second column says antibodies present. That'd be my question number 2. Don't go crazy yet. Can donate safely to. That's my question number 5. Last column, can receive safely. That's my question number 4. They don't have a column for question number 3. So at the far right-hand side, put a 3 right above that and put cannot receive, right? Scribble a little note to yourself that says cannot receive. And then go ahead and transfer this information into this table. So let's do this together right now. A positive blood. What antigens are present? A and RH. What antibodies are produced? B. Third column. To whom can they give? A positive, AB positive. To whom can they safely receive? The A's and the O's. Then over on the far side where there really isn't much space, who can they not receive from? The B's and the AB's. Let's do another one, shall we? I'll walk you through this one, and then I'll leave you to do one on your own for a moment, and then that'll bring us to the top of the hour, and we'll be excused. I'm giving everyone an automatic 5 points. There's no post-lab today, so I'm adding some points onto your quiz automatically today. Let's do B negative. Okay, and I'm not going to write down the questions again, but let's go through the same questions in the same order. Let's do this one together. B negative. What's going to be on the surface of the red blood cell? Just B. What antibodies would be produced? A and RH. Good. That's question number 2. Follow this logic. If I'm making antibodies against A and RH, that means I cannot receive blood with either A or RH in them, or else I would clump blood. So I'm going to draw an inward arrow. I cannot receive with an X. I cannot receive anything with A or RH in it. So what blood has A in it? A's and the AB's, right? But I also cannot receive anything with RH, so that's also going to include O positive and B positive. There are 6 blood types I cannot receive. They either have A in their name or they have RH. They have the RH factor. That only leaves 2 that I can receive, and that's inward arrow number 4. I can receive, no surprise, my own B negative, and as always, the universal donor O negative. So I can receive B negative and O negative. Is that logic making sense? Now, if I'm going to be giving my blood away, question number 5, what am I giving away? B. That means the people receiving my blood must already be cool, right? Already have their immune system adjusted to receiving B. That means they already have B. So what blood types can receive my B blood? Anyone with B in their name. So, the Bs and the ABs. 4 blood types can receive mine. Right? The B positive and B negative. AB positive and B negative and AB negative can all receive B negative blood. Go ahead and take a moment, transfer that information into your table on page 477 for B negatives. But I encourage you to also draw this out, and I beg you, do not memorize this table. This table is not to be memorized, it's just a place to put your information. But I want you to logically think through the logic of it. In an emergency, your memory will fail you. Your logic won't. So logically think through this. Don't memorize a bunch of little A, B, O's, and negative signs. You'll go crazy. Okay. Any questions or thoughts about B negative blood? I'm going to give you one to do, and then we'll check it. I'm going to be quiet for a moment, okay? So let me give you O positive. I give you O positive. I shut up for a moment, and you tell me in a moment what the answers are. Again, I do encourage you to draw it out. I just think there's something logically that flows from this kind of drawing out, and then transfer it into the table if you need to. Shall we check our answers? So, if you have O positive blood, what is on the surface of your red blood cells? Only RH. I want you to note there is no O antigen. O is the absence of A or B. So there's no O showing up here. O means no A or B, but there is still the RH factor on the surface of their cells. What, therefore, would they find foreign, and what would they make antibodies against? A and B. 2 different antibodies. Because they're making antibodies against both A and B, they cannot receive any blood that has A or B in its name. This is a lot of people being canceled out, right? I cannot receive anything with A, plus or minus, B, plus or minus, AB, plus or minus. I cannot receive any of those 6. Question number 4, by default, what can I therefore receive? O positive and O negative. I don't think that's a surprise, right? Because O positive, giving to O positive, that sounds good. And O negative will always, 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 you will see O negative as a part of your answer for question number 4. O negative every single time. O negative will be in your answer for question number 4. When I go to give my blood away, though, what am I giving to everybody? I'm giving away RH factor, right? So what must all my recipients have? RH. So all my recipients must be RH positive. So that's going to be my A positive friends, my B positive friends, my AB positive friends, and my O positive friends. Those 4 individuals can receive my blood. Every blank has a slightly different combination of answers. Okay? Every question number 5, every answer to question number 5 will have AB positive in it, won't it? Right? AB positives can receive from every blood type. So you'll always have an AB positive in your answer number 5. You'll always have O negatives in your answers to question number 4. Your answers to 1 and 2 will always be opposite of each other. Right? Whatever's in 1 will not be in 2. Whatever is in 2 will not be in 1. Fair enough? Okay. And I need you, over the next week, to think about the other 5 blood types that we did not discuss today, and to do them, and then I will be very pleased to go over or check anyone's work on the blood typing before we have a quiz next week over this. Next week I will give you 2 blood types randomly, and you'll have to answer these same 5 questions about those 2 blood types. Fair enough? Next week also we'll be doing blood typing. Again, it'll be voluntary. I'm not going to pass out the form. I ran out of time right now, but it's not a big deal. It basically says that next week blood typing is your choice to do it or not to do it. No penalty if you choose not to. The caveats are this: you must poke your own finger and you must collect your own blood, and nobody else can help you. So, you can't contaminate yourself, right? So nobody else can help you poke. Nobody else can help you do the test. You must do it yourself. But we'll provide all the reagents. Next week, we'll pull out our lab coats. We'll pull out, make sure you have goggles next week. Make sure you have gloves next week. And we'll do blood typing next week. And next week, we'll also be looking at arteries and veins, naming them throughout our body. We'll also look a little bit at the lymphatic system next week. So, are there any questions for me regarding heart or blood? You guys are going to do well on this, right?
Yeah.
Blood typing, some people have to do some little mental cartwheels. Work on it this week, and I assure you, if you'll spend a few minutes looking at it, you'll come back next week in good shape. So have a great Halloween.